Hey everyone, Chelsea here along with Nate and Logan. We're going to be discussing our learner-led lecture. We did ours basically on meniscal tears. We looked at the diagnostic test for a meniscal tear, the therapy used to treat different meniscal tears, and then also a modality that looked at that. The next slide is going to be Logan. He's going to give you the overview of our study that we chose for our diagnostic test, our PICO statement, the results, and all of the diagnostic accuracy of the study. So I'll go ahead and let him take that over.
Hey, I'm Logan Campbell. My partners were Chelsea Driver and Nate Blair. Today we're talking about the effectiveness of using the Tesley test for diagnosing meniscal tears. We're also going to talk about our PICO question, the article we use as evidence, the results of the article, how we can apply our findings in our practice, and also how to perform the Tesley test. Our PICO question was, in collegiate basketball players, is the Tesley's test an accurate diagnostic test for a meniscal tear in an injured leg compared to a non-injured leg? According to our article, the participants used in the study were between the ages of 16 and 56. They were chosen for the study if they had any signs and symptoms, including clicking, knee pain near the joint line, locking of the knee, and knee swelling. There was a bias when choosing these patients because an indicator for meniscal tear is clicking and popping in the knee and pain over the joint line. All participants received the gold standard, which was knee arthroscopy. Out of the 109 patients that were tested, 12 had no meniscal tears, despite clinical findings. There was an independent blind comparison between the index and appropriate reference, which was the gold standard of the diagnosis. The article states that the patients were given the reference standard by an independent observer blinded to the history, site, or nature of the meniscal tear. As far as our results go, we had the Tesley test was performed at 5 degrees and 20 degrees of knee flexion. The specificity of the test at 5 degrees was 68%. The positive predictor value was 78%. The negative predictor value was 31%. They did not list a sensitivity for flexion at 5 degrees of the Tesley test. Whenever flexed at 20 degrees, the sensitivity was 59%, the specificity was 67%, the positive predictor value was 83%, and the negative predictor value was 38%. So according to the article, 20 degrees of flexion is much more reliable than 5 degrees when using the Tesley test. As far as how we can apply this article and this evidence into our practice, the Tesley test is not the best in confirming a meniscal tear because the gold standard is still arthroscopy. But its positive predictive value at 83% when in 20 degrees of flexion shows us that we can rely on it to help point us in the right direction. But due to this, we should not rely on it just to rule out a tear, but have some confidence in it. So next I'm going to show you how to perform the Tesley test, first at 5 degrees flexion, and then at 20 degrees flexion. The goal here is to stand on the injured leg at first at 5 degrees and then at 20 degrees, and then you're going to internally and externally rotate. And we're looking for any kind of reproduction of symptoms, pain, popping, clicking, anything like that would be a positive indicator. So first at 5 degrees flexion, it's going to be almost a straight leg. I'm going to internally rotate and externally rotate. And we're looking for any pain, popping, clicking, anything that reproduces those symptoms. Next is going to be at 20 degrees flexion. And internally rotate and externally rotate. And again, we're looking for the reproduction of symptoms, which is pain over the joint line, popping, clicking, or anything that reproduces those symptoms.
So just to recap a little bit what Logan said there, we first thought that there might have been some bias in choosing the applicants. However, they were probably trying to have some sort of inclusion criteria since it wouldn't make sense that anyone with knee pain was included into the study. So it's important to take note of this when we use these tests and try to trust the outcomes of the tests. We will want our patients to have the same symptoms when we are using the test. And then also the gold standard was used and the steps were followed to make it a blind comparison. The results shown here are only the results for 20 degrees of flexion, but Logan covered both 5 degrees and 20 degrees. And then once again, I think Logan really talked a lot about this, how results will affect our practice. And Thessaly's is not the best in confirming or denying a meniscal tear, but it has a high positive predictive value score, so that allows us to have some confidence in it. Next, I'm going to discuss our therapy PICO question, which was, in middle-aged patients, is medical exercise therapy versus no therapy the best treatment following arthroscopic surgery of degenerative meniscus in the knee? So just a little background about this. Medical exercise therapy is a well-known and recognized treatment approach. It is defined as a treatment approach with its own criteria. The therapist is in the exercise room supervising the subjects, while the patients are treated with graded exercise therapy. The therapy consists of 1-hour activity. The history taking and clinical assessment is the basis for designing an individual exercise program, and the subjects are in a group setting consisting of a maximum of 5 subjects. Now, the researchers split the individuals up, which consisted of 70 participants. They were split into 2 groups. The first group was a high repetitive, high dosage medical exercise therapy. The second was a control group that was instructed not to participate in the rehabilitation program. To maintain the blinding of the study, 4 different well-experienced physical therapists with accreditation in medical exercise therapy did the testing and the exercise intervention. For the inclusion criteria, the subjects were with knee pain for more than 2 to 3 months. They had no considerable acute first appearance. They were 35 to 60 years old. Functional limitations in everyday life or physical activity, making the assessor evaluate the patient eligible for arthroscopic partial meniscectomy. And then they also could have an MRI showing degenerative meniscus tears. The patients were also recruited by orthopedic surgeons in 3 hospitals in the middle of Norway over 1 year. The subjects completed 82% of the rehabilitation program, and the degenerative and or other chondral lesions were found in 25 cases, 12 in the medical exercise therapy group and 13 in the control group. There were 15 patients who showed softening of the surface and 10 patients with partial thickness defects less than 1.5 centimeters. 12 patients of the degenerative chondral lesions with unstable flaps were treated by a debridement with a motorized shaver. 23 concerned the medial aspect of the joint. 12 weeks after surgery, both groups showed significantly better scores than after 1 month post-operative. Both after 1 and 3 months post-op, the medical exercise therapy showed significantly less pain and increased function compared to the control group. As you can see here, our CI was 0.63, our mean range was 1.27 to 2.53 for the one group, and then also 0.47 to 1.73. The study found that the p-value was less than 0.05 actually, not 0.01, which makes the findings statistically relevant. The mean range is based from the CI slightly overlap, so it is not definitive that the data is clinically significant. As far as how would we use these results in our practice, the data would have to be looked at independently, and without further research, we don't really know how to implement it in our practice. But the researchers found that for people who have undergone surgery for degenerative meniscus damage, postoperative high repetitive, high dosage medical exercise therapy is, in fact, an efficient treatment alternative compared to no rehabilitation. Finally, for our modality PICO question, we had in patients with osteoarthritis in their knee, can electric stimulation assist in the rehabilitation process by reducing pain? There were 63 patients used in this study. However, 13 dropped out before the study actually began. The patients were randomly assigned to a 12-week biweekly treatment. So 50 patients were split into two groups, which is very nice, 25 and 25. The first group was strictly physical therapy, and the second group was physical therapy with Russian stim. So at 75 hertz and a 250 pulse duration. Both groups were treated with equal amounts of electric stimulation. Nate and I are going to explain the procedure that was used, the inclusion criteria, and also the placement of the e-stim pads and how it's set up.
Hi, my name's Nate.
I'm Chelsea.
We're going to discuss the methodology aspect of our modality eco question.
In our article, the first step, they gathered the patients and asked them their pain on a scale of 1 to 10.
The second part that they did prior to treatment was they asked them a questionnaire, and this questionnaire was a self-diagnosing on their functional scale.
The third step, patients were told to walk 10 meters 3 times, and they were timed each time to notice fatigue.
The last thing they were required to do was they had to sit in a chair with handrails just in case. They were then asked to go from a sit to a stand without having to use their hands for support. They were then asked to walk 3 meters one way, walk 3 meters back, then sit back down without the support of their hands to make sure that they have the adequate strength. Alright, as far as the actual treatment of the individuals, though our focus in this was more how does the modality help with pain control, they also looked at the benefits not only with pain but also with strength gains and activation of the quad muscles, which will kind of describe why the setup is the way it is compared to what naturally you would see somebody set up for stem. The first part is just the positioning of the patient. They are asked to sit with their knees and their legs at 90 and 90. They are also asked to maintain good posture and keep their hands in their lap so that they are not using their hands to also support themselves during the treatment. Chelsea will go over the positioning of the pads as I grab this.
In the article, the pads are positioned over the biceps femoris, so that is where we are going to place these.
The next part that they did is so that the functional aspect of it, where they are testing the strength, which is not where our focus was, but this is how the setup worked, is they took a belt and they took a device that measured how much force output was given throughout the entire process. They positioned it just above where the shoe ends, and every time that they were to feel the electrical stimulation, they were also supposed to activate the quad. And after that, they then took a reading at each interval.
These are the results that we got from the study. The p-value was less than 0.01, which shows that it is statistically relevant and the mean ranges do not overlap. And these are our references. I hope you enjoyed.